You kept speaking about sexual function, and I want to kind of tap back to that already and kind of maybe define what sexual function is, because then that could we can then kind of go into possible sexual dysfunction.
Well, sexual function then would, of course, relate to the experience and actually being able to have the sex really should be with the pleasure associated with sexual function. Mm-hmm. And sexual dysfunction, and we tend to learn a lot about the dysfunction in men. Mm-hmm. Talk about your erectile dysfunction, premature ejaculation, but there's sexual dysfunction in women also. And I do believe one of my colleagues actually did a research on that in Barbados as one of her, for her thesis for her Doctor of Medicine. Mm-hmm. In at sexual dysfunction in females. I can't right now quote the specifics, right? But we tend to forget about the females when we talk about sexual dysfunction. There's this assumption that females get orgasms with penetrative sex. Maybe 30% or less actually do, right? It's not a high number. And then there is the thought that's associated, all the mental health aspect of it, where you're supposed to do this and always be available for a partner and so on. And all of this can lead to sexual dysfunction. And I won't get into the specifics of it, but when you look at what happens with sexual arousal, male and female, it's quite different in what happens in the brain as well. Women need this while men will.
So we need another session for this, clearly.
That's a whole nother thing, right? But it's important that we discuss sexual dysfunction in women. Mm-hmm. A lot has been done for men, but then we have sometimes neglected the issues that women face. Some of it also comes from medical issues. Mm-hmm. Do know one of the symptoms of endometriosis could be painful intercourse. Yeah, this part, yeah. So it's important that clinicians, healthcare providers, counselors dealing with sexual and reproductive health do ask these questions from clients mm-hmm. to determine, is this someone who may benefit from more intervention, right? Mm-hmm. Because they're experiencing sexual dysfunction.
Another aspect I'm going to touch on, a really contentious issue, is comprehensive sexuality health education. I know it's contentious for some reasons, but what is the evidence behind it? And then, is there practical applications to it?
Well, I mean, for decades, this is nothing new. This date back maybe near World War II, maybe sometime after that or so on. When you look at the literature in some countries, Nordic countries in Europe and so on, have been doing sexual education for some time. And so for decades, different entities, different bodies have been trying to establish health and family life education within school systems. Mm-hmm. Some got some mixed review and results, but there is strong evidence that the comprehensive sexual education improves knowledge about sexually transmitted infections, especially HIV. Mm-hmm. I'm still sometimes, and rarely this happens, but once in a while I'll ask a set of young adults if they know what HIV is, what HIV means, human immunodeficiency virus, and even that is not being able to say, especially with all the focus on HIV over the years. It's still like,
so what is that? Oh.
That age group, sexually active, we don't know much about HIV at all. So the comprehensive sexual health education does improve knowledge about STI self-efficacy related to making decisions.
Right.
In sexual health, condom use, when to refuse sex. Mm-hmm. And it contributes to delayed sexual debut and increased condom use, which of course will lead to less STIs, such as HIV, and unwanted pregnancy, right? And teenage pregnancy. So in Europe, they were looking at a group of countries which use the comprehensive sexual education as a tool to look at how it can affect their sexual and reproductive health in their country. And they found that the countries that incorporated it use more modern, reliable contraception. You know, that was more prevalent, and they had low teenage fertility rates. And there's this talk, and I guess that's why you say it's so controversial. There's this talk of that if you do it, they're going to have sex earlier.
Right. They think of it as not just promoting sex,
right. Encouraging earlier sex. The studies have shown that that's not true.
Right.
That is not true. It does not make a difference. The age that sexual activity starts. So the fact is, sexual activity average around 15 or so, 16 years old. It didn't differ in those countries with comprehensive sexual education from countries that didn't have it. But what differed was the outcomes.
Right. The
sexual transmitted infections, the pregnancy rates among teenagers, and so on.
And they're also more self-aware to know what they wanted when it
they wanted. Yes. They don't want.
Exactly. And
exploitation and so on.
I think that's really important because for me, I didn't have comprehensive sexual health education growing up. I just had the basics in like biology, and I think I would have, I guess, if it had also incorporated self-efficacy, incorporated, you know, the whole notion of sexual function and sexual dysfunction, that I think myself and maybe a lot of others in my generation would have known a lot, obviously would have known a lot more, and maybe have been, I always say I would have probably been in a better position to handle my endometriosis diagnosis at that point in time, that compared to my response outside of having, you know, the education about menstrual health and menstrual health disorders. And I do believe that the menstrual health conditions are also incorporated into some aspects of comprehensive sexual health education. So that's my whole point of saying that if you incorporate, these concepts into the education, you are better prepared for a potential outcome, because then you know what to expect post-diagnosis. Yeah.
Great. Well, I went to an older Catholic high school, secondary school. I know we had, I can't remember if it was comprehensive. I have very little recollection of it, to be honest. So I can't say if it was comprehensive or not. I will say I knew something, and you know, the next thing is the cultural aspects around it, from your family and so on. I can't recall ever having the talk.
I didn't have it either, to be fair. I don't think
I can't remember having the talk, to be honest. I don't know if it did happen. I remember being told at one point, don't come home pregnant. So,
but that was it.
I can't remember if there was much else leading up to that, but that is edging my brain, you know. So I think moving forward, again, the perception of the community and the taboo and the secret and not, you know, trying, the literature has shown it's not going to make a difference in terms of sex being happening earlier, but it might make a difference in terms of the decisions being made. Some persons are actually being abused or exploited and don't even realize.
Yeah. So then they're given the information about detecting, you know, signs of exploitation, signs of abuse, and then they could go and be like, oh, that's what's happening, and then make steps to get help.
Right.
Yeah.
And you mentioned the menstruation and menstrual health being incorporated. And I think this should be taught to both boys and girls.
Completely agree. Completely agree.
Yes, we know male boys don't get periods, but they need to understand what it entails, the complications or possible abnormalities related to it. They have to interact maybe with another a partner, if a sister, a mother, a daughter, who may these challenges, and if they understand from their end, might be better able to, offer support. And it's the same vice versa. I think the girls should be taught to the issues and the things that boys will experience. But that it shouldn't be you get all the boys out of the class and you just teach the girls about menses and their menstruation. And I have seen where persons still misunderstand. I don't think persons understand what a menstrual cycle entails really, and the possible when it's abnormal. And I say that because and this doesn't happen often. It was just like one or two times. In the case of, say, an adolescent girl got her period for the first time, and her mother took her to the doctor. There are no issues, no pain, not heavy bleeding. It's just that the period came, which it's supposed to. She's not too young or too old, then I worry about what you're saying to this young girl about her period, needing to come to the doctor without an issue. Right, without an issue. And then to identify when you should come to the doctor. I remember sometimes seeing someone who say, oh, I get bad cramps all the time. That's normal for me. Bad cramps to the point that you can't function, you can't do anything, and so on. And in a few cases, sometimes it ends up being something like a tumor. Because I said, no, well, because the person was like, I just want painkillers, I just want pain. No. I took the history and so on. This needs a little more, needs to be looked in a little further. You really shouldn't be rolling on the ground and can't even, that's not normal. Okay. And then, of course, endometriosis is another known cause of this pain associated, very bad pain associated with the menses. And some people still have no idea what endometriosis is or never heard the term. I remember when Jasmine came on campus to promote their book, and we spoke to some students and said, oh, come and listen to this talk about endometriosis. And they go, what's that?
Yeah, that's why we decided to do the book, because we recognize.
Right. So kudos on the work you're doing.
Thank you so much.
The presence on social media, because you know that persons like their social media, their Instagram and so on. Apparently people don't use Facebook anymore, I've been told. Maybe that.
I still use it, but yeah.
So use Facebook, okay. Right, but to get the word out there that even if someone, and I remember when we were doing one of the walks, and a man on the street go, "What is this? What is this?" And I said, "Endometriosis." He said, "What's that?" And we go, "Well, we can stop and tell you about it." To raise awareness about this common condition, pretty common,
very common condition, and next. Right. P.C.O.S awareness, so look out for that too. Very common condition to probably, right now I think it's more common than endometriosis, simply because numbers
and people are being diagnosed, and so that
it's easier to diagnose. Is way easier to diagnose.
It's much it's just fulfill a criteria and that's it. Endometriosis can be a little bit more challenging. And take some time to really get to diagnosis. And just one thing that I thought was interesting in looking at some reports from UNESCO and so on, that in some countries, there are actually still reports that 2 out of 3 girls, when the menses start, they have no idea what's happening to them.
So we still have some work to do.
So I don't think that's the same in the Caribbean, that, but it's just worldwide then that this is still an ongoing problem in terms of incorporating good sexual health education, comprehensive sexual health education, especially on menstruation, because that's pretty high.
That's pretty high. 2 out of 3 is
right. That what's happening there when the period comes, right?
Yeah, no, that is something that needs to be addressed. And then
so I thought that was interesting to see.
That is interesting. That is very interesting. So then, what are some of the best practices to address these barriers that are presented by the stigma and taboo and discrimination that we are so aware of happens in our society? it would be, I guess, like being an ostrich and putting your head in the sand to say that this does not happen. This does happen, but what can we do to address it when it comes to sex and sexual health?
First, we have to identify them,
Mm-hmm.
and then be able to address them, look at different type of barriers. I just would like to mention here, one barrier could be legislation. When we talk about age of consent, and in the sector I work, that's very important, because yes, we do have persons sometimes who are under 18.
Mm-hmm.
Based on the Barbados law, age of sexual consent is 16.
16.
Age of consent to like medical procedures and so on and so on is 18.
Yeah.
And other countries have actually raised their age of consent
to match,
to try and prevent exploitation and so on. But it's still a very gray area.
Mm-hmm.
It's still a very gray area. But what persons don't know in Barbados, if doctor or medical practitioner, and this is in our code of conduct, if you can declare a minor mature, a mature minor, and you can satisfy that this minor has sufficient maturity and understanding of their condition and appreciate what is involved in the management and the treatment, then you can, and they don't want their parent involved, depending what it is, and it's in the best interest of the minor, then you're supported by judicial precedent to incorporate in a course of action that can be, but this of course has to be justified on the medical record.
Right.
But actually, Termination of Pregnancy Act 1983 allows for a 16-year-old to consent without consent to a termination of pregnancy under 12 weeks gestation. That's another thing that some persons may not be aware of,
because I don't think I was aware of that. Yeah, I was aware of that. Yeah.
Yeah, they can. And I've had the experience of a mother, most times a mother. We recently saw on social media, right? It was T.I., rapper.
Ooh, that situation where he took his daughter to the doctor to check her hymen. Yes.
Yes. How old was she? Like,
I think she was between. I don't want to quote her age, but she was.
Yeah,
I think
I can't
she was
remember.
age.
But I smiled when I saw that, because but it's usually the mother who would bring, and I remember a 17-year-old. Oh, she wants to know if she's having sex. She wants to know, well, I always ask if I can speak to the
Child patient
on their own,
mm-hmm.
on their own, without the parent present, and usually they say yes. Because first I want to make sure I establish that there is not an abuse situation occurring.
Right.
Right? This is not any sexual abuse or anything like that occurring. But then when I have to say to mommy, well, she's 17 and the age of consent is 16. So I can't go examining her and telling you, I get cursed off, but it's okay. It's fine. Mm-hmm. It's okay. And even when they're over 18 sometimes, and I work in a setting where, parents believe because they're paying the money, that all the information, right? Mm-hmm. And I call to make queries, and you have to say, well, remember, they're over 18. I can't disclose without permission. Mm-hmm. And written permission at that. Yeah. And I ask specifically what I should disclose. Always ask specifically what I should disclose, because it's not everything you might want disclosed.
Disclose, exactly. And
right. So the legislation as one of the barriers.
Yeah.
It's not clear cut. That's actually a very great area.
Mm-hmm.
And of course, there are other barriers in terms of access to the sexual and reproductive health services, mm-hmm. information, and so on.
Right.
Especially in special interest groups. And behavioral barriers, which is what we spoke about in terms of being able to offer comprehensive sexual health
education.
Behavioral barriers, cultural barriers. Yeah.
Yeah. So we can identify these barriers, and I guess with the exclusion of the legislative barriers at this point in time, the most we can do to address behavioral, cultural, social barriers is just more education, more education, more education.
And put it out there. We don't see enough. I don't really watch TV in terms of, TV with and so on very often. These days, you want to watch something, you just find a show on Netflix or whatever and you watch it. Interrupted. So I can't say if I've seen enough on TV in terms of pushing these kind of messages, but definitely social media,
right?
The best areas, and keep talking about it. We keep talking about it, and we also need to educate the young persons, the persons or the different special groups that these affect, and have them to as advocates.
Yes, because I know there's a special group that equals Barbados advocates for, and I'm the word that they the LGBTQI plus community, and they're doing a phenomenal job in that aspect. But you're right, there are other special groups, like you're right, like the elderly, because even when I kind of decided that this is a talk that should be done, I personally wasn't thinking about the elderly. I can admit that. And you're right, that is a group that we tend to forget, and more needs to be done for them. But then also educating our younger citizens from as early, and it also needs, the education obviously will be catered towards the age group. I think that's also another fear with CSE, it's just going to be like a free for all, and they're just going to get all of this, adult information too soon, and that's not the case. You can cater it to suit the age group.
Right. And that's the thing that they don't understand. The education has to be catered to the age group. You won't be telling a 7-year-old something that a 13-year-old what you tell the 13-year-old. So it's tailored to that and evidence-based.
Exactly, always evidence-based.
Yes. So that's just all misconception, because persons don't know and don't understand. So it's our job as professionals in the healthcare field to put the information out there, to put the educate persons out there about what it entails, and so that there's a better understanding that we're not going to tell your child to go and experiment and do anything.
No, that's not the case. It's about them to be self-aware, so that they know when they are ready and their age.
We want a 10-year-old who may see their period go, okay, there's blood. Why is there blood? Oh, I'm probably getting my period. From my mommy or whoever. Right? Or know that someone is exploiting them.
Yeah, I think that's really, really important. And that's also an aspect of sexual health. I saw that WHO had this document where they kind of outline the specific areas that kind of fall under sexual health, the specific areas that fall under reproductive health, and I believe under sexual health, it's addressing, I'm not paraphrasing here, but it's along the lines of looking at things like intimate partner violence and addressing exploitation and abuse, and that sort of area within sexual health that comes under like sexual abuse and that. So I do think that you're right on understanding these signs and recognizing these signs for yourself and maybe someone else is also critical to the whole concept of sexual health. It's not just about having sex and STIs, like
and just making healthy choices, just making healthy decisions, empowering to make better choices as adolescent into adulthood, because that can be a very difficult transition.
Yeah. And it will be made a lot easier with as much relevant information as possible.
Support as possible.
Completely agree. So you kind of spoke about your role in family medicine as a physician with patient-centered care. So I guess I can skip to the final question. This was great, by the way. This went far beyond what I anticipated, so thank you for this. But to round off the discussion, what else would you want the audience to take away from this specific chat where we're talking about sexual health, but then about family medicine in general?
Well, the pinnacle of patient-centered care is shared decision-making. The Institute of Medicine truly describe patient-centered care as a care that is respectful and responsive to the individual's preferences, their needs, and that help to guide the clinical decision process. So patients feel more involved than in their care, right? And feel like part of the process, less discomfort, they get to be more trusting, less mental health issues, and it leads to fewer visits to the doctor. Yes.
Which
and
is
fewer referrals and also investigations. Because then, you know, we family physicians, we always like to ask, you know, so what are your thoughts then? You know, sometimes someone coming with a complaint, they're usually when they come, they have some expectations, they have some ideas of what they think might be wrong with them, and they just need you to reassure them or help them to come to that process of being reassured that, okay, maybe I don't have cancer because I have a cough.
right.
Not because I have a cough, you know, or my headache is not a brain tumor. Right? Things like that. So it's try to help them in the decision-making process and as I said, share decision-making, and that then eventually will lead to these better outcomes. Family medicine is a one-stop shop. I would like to mention how the UK system works, where persons have a general practitioner. So even if you're seen by a specialist in a hospital and so on, information is sent back to that general practitioner, which is really their family physicians.
Right.
It's just a different term used in their setting. And that helps for good continuity of care. And I'd love to see where we can move towards that in the Caribbean. I've seen many problems because of that lack of continuity of care.
The disjunctedness,
Yes, persons taking double medication from 2 different clinics and doubling up on things that, you know, they shouldn't be doubling up on because one person doesn't know what the other is doing.
Right.
Some of the problem is, you know, there are some persons who like to doctor shop, right?
There's nothing wrong with getting a second opinion.
And don't get me wrong, nothing is wrong with getting a second opinion.
But if you're just,
But sometimes you have to say to a client, but you know, you haven't given this person a chance to finish trying to solve the problem for you. You know, giving them a chance to do that. So when you go to someone new, they have to start from scratch, especially if they have no idea what was done before.
Right.
So time is a factor. You're spending more time trying to find out what's going on, more money because you might have to do more tests or repeat tests that you already did that would have not been repeated otherwise, and so on. So I advise persons to find a family physician, general practitioner that you trust, that you have a good relationship with, and make that your one-stop shop. Even if you go elsewhere, bring back information to, even if it's just to put on your files, not necessarily to see, but just put on your file that if you have any other issues, any concerns, that your practitioner, your general practitioner, your family physician has that information and can help guide the whole process. As I said, the center in the netball.
And you can direct if they need
to. We can't send the ball that way or send the ball that way, right?
Yeah, so
unfortunately, we can't shoot the ball in center.
No, but we can guide you. So we can guide you to an OBGYN, or you can guide them to an endocrinologist.
If necessary.
Right.
There are quite a few things that a family physician can manage on their own without referrals. You know, some mental health issues, a lot of gynecological issues, you know, quite a myriad of things that would not necessarily need referral once you have the right training. And it can be managed in-house.
Right. But I guess from a patient's perspective, it's also important for the physician to recognize, all right, this is something that I need to refer out. So it's important to recognize.
Yes. And you have to know when you need to refer.
Right.
Some things might be because you're not comfortable, or you don't have enough training, or you don't know, and that's fine. Then you'll be able to refer as necessary, and that might be actually in the best interest of the patient.
So it's good to have that one-stop shop that houses everything. everything. And then whenever you go out, you can still bring that information back and you have
Bring
that.
the information in. Yeah, it's not to stop you from going out. It's just that one place where all the information is.
Yeah,
And one you trust who can help you to navigate all of what your healthcare needs are.
and that's an important point. The navigation is something that is really critical. So I appreciate that. I really think that this was a very comprehensive, yes, that pun was intended, comprehensive discussion given the time limit that we had. I'm hoping that our viewers understand what family medicine is, recognize that there is a difference between sexual and reproductive health, even though that they are usually presented together, understand the concept of safer sex, recognize that, you know, comprehensive sexual health education is something that should aid in increasing education and allowing us to recognize, you know, we have the power to make those decisions based on our sexual health with as much evidence-based information as possible, and that, you know, your family medicine practitioner or your general practitioner can act as a navigator for you whenever, you know, you want to make specific health decisions, and they're there for you to guide you through the way and act as your quote-unquote one-stop shop. So thank you, Dr. Whitby-Best. It was really a pleasure having you. If you want to know more about Dr. Whitby-Best, I will put some more contact information. It probably is going to be UWI's contact information, yeah, in the content underneath, as well as our end card. And so, yeah, thank you again, Dr. Whitby-Best. It was a pleasure. I will sign off now. So have a great rest of your evening, everyone. Bye.
Well, thanks for having me. Just one thing, just want to remind everybody, 3 W's. Wear your mask, watch your distance.
Thank you for that. Thank you for that reminder. Bye.